Hello, everyone, and welcome to the Rural Emergency Hospital Education and Fireside Chat. We're so excited to have you with us today, and we also have two CEOs that will be chatting with us later in our presentation. We do have a packed agenda, so we're going to get started and give you a brief overview. If you've joined with us before, you may have seen some of this information, but if you're not familiar with the REH designation, we're going to go over at a high level the policies and requirements of being an REH. We're also going to talk a little bit about the Rural Health Redesign Center and the technical assistance that's available to all of you. And again, we'll have our fireside chat. Ken will be leading the discussion with Lynn Lacefield, CEO of Clinton Regional Hospital, and Kevin O'Brien, CEO of Harper County Community Hospital. And then lastly, we'll close out the session with our resources and next steps. As always, we want to note that we work of the Rural Emergency Hospital Technical Assistance Center is funded by HRSA. And the United States Department of Health and Human Services. And then this is our HRSA disclaimer. The REH TAC is funded by HRSA and the United States Department of Health and Human Services. The contents of the authors do not necessarily represent the official views nor an endorsement of HRSA, HHS, or the US government. We have Ken Harmon, the Program Director of Rural Emergency Hospital Technical Assistance Center here at RHRC. And then my name is Rachel Tarpley. I'm a Project Manager here at RHRC, supporting the Rural Emergency Hospital Technical Assistance Center, and I'll be your moderator today. Before we get started, I'll go over a few housekeeping items. You notice that you were all on mute. This is to avoid background noise. We do encourage you to ask questions, so please feel free to use the Q&A feature. You'll find that at the bottom or at the top of your screen, depending on your layout. If you do need closed captioning, this is available. You will need to click on the More option with the three dots at the top or bottom of your screen, and then select the Captions option and the language. And then also the slides and recording for this webinar will be available on our website within 1 week of the event. And if you have any questions, you can follow up with the REH support at rhrc.org. Okay, just wanting to go over our objectives for today, which are to provide you a high-level overview of REH, review REH policies and requirements. We also hope to have you learn a little more about the technical assistance we offer to the rural emergency hospitals. And then again, most of the portion of today will be spent in the fireside chat with our CEOs.
Thank you very much, Rachel. We appreciate your assistance and help. We couldn't do this without all of the effort that she has. We're going to talk a little bit about the organization and about our processes. The Rural Health Redesign Center, which houses the Rural Emergency Hospital Technical Assistance Center's goal and objective is to really help protect and promote rural health care across the country. The REH program, which probably a number of you know about, was established on December 27th of 2020 in a new legislation which created a new permanent model for healthcare. It became effective starting January 1st of 2023. Of course, the purpose of this particular model was to address the growing closures of rural hospitals around the country. When Congress put this together, they looked at how can we maintain some core essential services in these rural communities, and how can we try to make sure that we have access to appropriate care. This program has some eligibility requirements and other things. And I'm not going to read all of this slide to you. I'm just going to highlight a couple of the things that hospitals have to have in order to be eligible. Number one, they had to be licensed with Medicare and had to be in a rural area and have 50 or fewer beds or be a critical access hospital. Those things were very, very important. Now, we've had some hospitals that have closed after December 27th of 2020 that reopened. And Lynn, who's the former CEO, is going to share some of his experience because he took a hospital that was closed and reopened it and then applied and had it convert into a rural emergency hospital. Or we have hospitals like Kevin's hospital that was already serving as a hospital and made the decision to convert. So you'll be able to learn from some of their experiences and their examples. Now, in the rural emergency hospital program, there's certain services that are required to be provided. All REHs have to have this service. You have to have an emergency room and observation beds that are available for the appropriate patients 24/7. You have to have the appropriate support services to provide for that emergency room, meaning you have to have some certain diagnostic lab and radiologic services. You have to have the medications to be able for your providers to provide care to those patients. And you have to have a discharge planning process for those patients in your ER and those patients in your observation stay to ensure that as they're leaving your hospital and either going home or going to a different level of care, that process is defined and appropriate. In addition to those required services, when the federal government put this designation together, they said that the organization can effectively offer almost any other almost any other outpatient service. So the list you see in front of you is certainly not an exhaustive list. This is just a few items that could be offered by rural emergency hospitals. We have some hospitals around the country that have surgery. In fact, I know of some rural emergency hospitals that do total joint surgeries. We have hospitals that do cardiac and pulmonary rehab. We have hospitals that have lots of clinics, rural health clinics or provider-based clinics. We have PT clinics and other things. In addition to these outpatient services, the Rural Emergency Hospital Program allows hospitals to have a distinct part, skilled nursing facility. So they can still provide a small segment of services that would be considered potentially inpatient within that distinct part nursing facility. Of course, that has to be separately licensed and run by the organizations and have a separate Medicare certification number. But literally, the outpatient services, it really depends on what the needs of the communities are and what the organizations want to do. In fact, we've done a lot of technical assistance with organizations, assisting them in looking at and adding services to their community. Now, as we look at the rural emergency hospital, hospitals convert for a number of different reasons, but one of the most significant reasons is the fact that there's financial model differences that bring in funds to the organizations. It's about $3.6 million a year that they are receiving in a monthly facility payment. It works out to be a little bit over $295,000 a month right now after sequestration that each of these hospitals receive. Now, these funds, the reason Congress has given this to them, that is intended to be able to ensure that they maintain that core level of service, that they're having their ER open, that they're having the lab and the imaging and the medications and the discharge planning processes. And then all of the other services that they choose, the revenue from those hopefully are enough to pay for those services. So in addition to that $3.6 million, the gain of converting to a rural emergency hospital is that they also receive a 5% bump or 5% increase on the outpatient OPPS payments. So it's not all outpatient services, but it's that subset of those services that are offered within the hospital under that OPPS schedule. Other outpatient services are paid still on the fee schedule. So if I'm doing routine labs and things, those prices aren't changing, those revenues aren't changing. Those are the big pluses. And as we go through as an organization and do financial models for a lot of hospitals, looking at and determining whether this is an appropriate change for them, but we see that these, for a lot of the lower volume hospitals, really significantly increase the financial stability of the organization. But with the model, like all things, there are things that they have to give up or things that they lose. They're required to close all inpatient services. And part of that inpatient services is the swing beds. They're not currently eligible for any 340B drug pricing. And if they happen to have been a critical access hospital, they're no longer eligible to receive cost-based reimbursement. And so when you have these pluses and these minuses, obviously it creates an environment where for some hospitals that do assessments, it makes absolute sense. And for other hospitals that we've done assessments for and work with, it does not make sense to convert. And of course, we're happy to help all hospitals do this evaluation. And because of the funding for HRSA, we do all of this at no cost to the hospitals. Application requirements or process. The federal government has made a fairly streamlined process. When the organization makes a decision that they would like to convert and to become a rural emergency hospital, they go in and they do a change application. So it's not a brand new application for a new hospital, but it's a change application. And you fill out a number of different questions and submit it, and then you have to attach certain documents. You have to attach an action plan or a transition plan. You have to demonstrate and attach at least one transfer agreement with a level 1 or a level 2 trauma center, and you have to attach an attestation. Now, certain states have you attach other documents as well, and through our REH TAC process, we certainly will help the hospitals go through this if they've made those decisions. The application process does take a little bit of time. I think Lynn when he took the group through Clinton Regional, probably had one of the quickest transitions I've seen. We've had others that have taken 4 or 5 months. And so it goes from a few weeks to a few months, depending on when they get their file complete and when the MAC and when the state and when the CMS agency all is able to get their tasks done. They're, of course, going to validate that you are eligible. They're going to validate that you have included all the information and that your action plan is complete. In addition to the things we've talked about, the Technical Assistance Center for the Rural Emergency Hospital Program provides a lot of education. We give organizations a lot of different tools to assist them in communicating with their board or with their community or with their medical staff or their employees. We provide a lot of assistance to organizations in putting together that action plan or that transition plan. And we have tools that will then help transition that action plan into maybe an annual business plan or a smaller strategic plan. And then we do a lot of work for these hospitals on a post-conversion basis to ensure that they're able to be financially viable, that they're able to become compliant with the conditions of participations, and that they can grow services and continue to be successful in providing services for their communities for years to come. Again, this just goes through that conversion process. And again, Len, when he talks about his process, he'll tell you how he was able to make it go very quickly. But again, others might take a number of months. We're now going to move a little bit into the fireside chat. I think, Rachel, are you going to introduce the 2 wonderful speakers that we have? So
yes,
I'll hand it over to Rachel.
So first and foremost, we have Kevin O'Brien, who is the CEO of Harper County Community Hospital in Oklahoma. He brings more than 36 years of leadership experience in Northwest Oklahoma hospitals. For over 5 years, he has overseen the operations and finances of Harper County Community Hospital, 2 rural health clinics, and the area's emergency medical services. Under his leadership, the hospital has expanded access to primary care and emergency care, improved operational stability, and continued to serve as a lifeline for patients in Harper and Woodward counties, as well as in Southwest Kansas. Welcome, Kevin. And next we have Len Lacefield. He's the former CEO of Clinton Regional Hospital in Oklahoma and brings over 40 years of experience in healthcare. He has a unique experience that includes startups, owning and operating and expanding medical facilities and systems, managing large organizations as well as rural hospitals. He's known as a visionary and strategic innovator and has successfully reopened multiple hospitals and transformed underperforming facilities. Len continues to influence the future of rural healthcare through his leadership, service, and industry expertise. Welcome, Len.
Thanks, Rachel.
And I'll hand this back over to Ken.
So now we're at our fireside chat portion. So I'm going to stop sharing so you can maybe see Len and Kevin's faces a little more clearly and not have to see the questions. But we've got a few questions that we have, but we also would certainly like to open it up to you. And if you have any particular questions, please put them into the QA session, and we'll be sure to make sure that those questions get answered. So first, I will ask, we'll start with you, Kevin. Walk us through the process for your organization. How did you make the decision to become an REH?
Okay. Well, we struggled for years as a critical access hospital. We're in very far northwest Oklahoma. We only have 1,000 people in our community and only 3,200 people in our county. So for the past probably 15 years, we were always losing money year after year after year, and our census kept dropping. We had almost no census. So we got in touch with the Technical Assistance Center. They helped us do an evaluation to see if this program would help us provide better care for our community. We then, based on the numbers, they were good. We then reached out to the community. We had to have several town hall meetings and to get their support and stuff. And then in late August of 2023, the board made a motion to make us become an REH. And we became an REH effective October 1st of 2023. So it was a really quick process. I will say, though, that right after the transition that we did face some, the communities thought that we had closed and stuff. So we had to do a lot of education. We had to do a lot of marketing to understand that. But we have been able to expand service lines by quite a bit. So it was a good thing as far as we have not lost money in the last 2 years. We have not had to lay off any staff. We've been able to be competitive in the market and stuff. So it has been a very, very good thing for us. It stabilized our economy and made sure that the community was taken care of, because we're 40 minutes from the nearest town on top of that. So that was a big deal.
Thank you very much, Kevin. Of course, we'll get into some more questions a little later on about some of those processes, but thank you for sharing. Len, you have a little different experience. You went to a hospital that had been closed. So maybe you can talk to us a little bit about how you opened it and how you made the decision to become an REH, and a little bit of your journey in that process as well.
Sure. First of all, Rachel, if you'll send that introduction to me, I want to read it to my wife every night for the next month and see if she has a change of opinion. But I have been blessed or cursed by being called to open 2 different hospitals in the state of Oklahoma. I've spent about 42 years, and I just have a deep heart for rural health. And I actually was married to a physician in 1983. And so we opened our first primary care office then. So I go way back. I was a little bit disappointed that I had more years of experience than Kevin, but nonetheless, I think we both have long teeth and have experienced a lot of things. But when I went to in September 2023, I was called out to Clinton, Oklahoma. The hospital had been closed due to mismanagement in December of 2022. And the facility and the location and the opportunity and need in the community was overwhelming to the community. So I dug in. I spent the next 9 months, most of the time in a hotel there. Took 17 people, and we began to rewrite the bylaws, protocols, and things. We did that over the next 29 days and reopened the hospital in 30 days. After that, we were, this would have been October 31st. What a day to reopen a hospital, Halloween, right? After that, we got surveyed in January 10th, and Medicare licensure in the first of the year of 2024. As we began to, as you're all familiar with, work with our RCM and softwares, what a critical piece of any equipment and sustainability. We were unfortunate. I actually inherited, interesting, I inherited a contract that was signed in June of 2023 when the hospital was closed and had no license in the state. So I really am not sure why anyone had signed that contract, but nonetheless, I was living with that. Had to do some changing. So as we went forward and we looked at the landscape, I've had great opportunity to network with actually with the RHRC in October of that year. I went to Bethesda, got to meet Ken and Kayla and many of the people that, quite frankly and transparently, they're saying, we're trying to figure this transition out because we see the need, we have the opportunity, we have the tools. How can we get it done? So I think at that point in time, there were about 29 or 30 facilities. I was not converted yet. I was still kind of the stepchild of the room, but I learned a lot. So I think I had an advantage because I had actually got to get inside of this wonderful team and the TAC team early on. We had some issues with licensure as far as the date. As Kevin said, the 12/27/2020, where our first run was a little difficult and we did not process. But then at the end of last year, actually, it was just before Thanksgiving, we made a run at it. Wonderful. We turned in all the data required by the state and by CMS and MAC, and the government shut down the next day. So what I did was I went ahead as if the government was open, and I began to drip on everyone from CMS and MAC and the state. I was able to have the state come out and survey the hospital about 6 days before the government shut down, and they have 10 days to get back to you your results. Well, I had a sidewalk I had to pour, and I had a biomed tag that was outdated, and I had to wait for 42 days to get that data back till the government reopened. So we were already locked and loaded, for lack of better terms, and it took us about a week and a half after the government reopened. So I think I counted 64, 65 days to convert or change our taxonomy. But I will tell you this is the team with certainly Kayla and Ken and certainly Dan, but the entire team was a profound reason why we're able to convert quickly. So we did that. That was a decision we made, quite frankly, because we'd gone back to the core question to the city on a number of occasions after they'd stockpiled about 13 million way back before 2022. They were good stewards of lease payments to larger hospitals. But just the crisis, of rural healthcare and the inpatient volume, we were losing money. And when you look at that, before in 2023, the tag team came out and they did that analysis that Ken was talking about, and that's going to be something I'll address later in the end. But Ken, I think that the opportunity, it excites me because I'm an innovator, and it didn't bother me a bit to close down inpatients because you can lease your space to anybody you want. You can do any number of outpatient services to help regulate your financial structure. So that was the length of my decision-making process, and I think it was the best move that, quite frankly, anybody could do in rural healthcare in today's environment.
Lynn, thank you very much. Kevin, I'll bounce back to you. In your initial comments, you talked a little bit about how the community initially responded to the conversion, thinking that the hospital had actually closed. Maybe you can share a little bit about what kind of education, what kind of communication did you have to help them understand what the model means and what services you're offering and continuing to offer and even growing for your community?
Sure. For us, part of when we did the town hall meetings, we kept telling them that we was going to expand outpatient service lines. And so besides doing the education in the newspaper, we lived up to what we said we were going to do. So we had, just to start with, we had like your lab, your CAT scan, some physical therapy as mainly our core outpatient services. But with the inpatient shut down, it opened up that whole floor to expand to outpatients. So at that time, then we expanded into pulmonary rehab for patients. We're doing wound care. We're doing sleep studies. We're doing the other stuff that we're doing is like we're looking at pain management for our clinics as well, trying to do that as well. We are got us a social community health outreach worker trying to meet the social needs and the needs that we haven't been able to meet in the past as far as that goes. So we continue to expand all those outpatient areas as far as that goes. So it's made a huge difference for us. We've almost used up all of our inpatient space. In fact, we're thinking about we're going to have to figure out another building to expand some of our outpatient services too. So
thank you very much. And I mean, those expansion of services, now the community is looking and you're actually interacting with more patients and providing more care than you did even before. So very exciting to see the work you've done. Lynn, I know that you've also added a lot of services and helped. Maybe you can talk about how you communicated with the community and share a little bit about some of the things that you brought back to the community and things that you added to the community they didn't even have before.
Well, I think that you have to keep in mind my story is on the end of a closure. So just to reopen the hospital was something that really blessed the community. Um, Clinton is about 8,400 people, and our draw is bigger than Kevin's. We're right on I-40 in western Oklahoma. We have two neighboring cities about 30 miles to the west and about 20 miles to the east. They both have, well, one is a critical access hospital, one's a PPS. But we weren't meeting the community needs. So one of the things that we did, we partnered with Pritikin, Pritkin, to open up a cardiopulmonary intensive care rehab program. There's only two in the state of Oklahoma. Mercy Heart has one, and believe it or not, Clinton Regional Hospital has one. And that's become a significant revenue source. As Kevin said, I think the analysis of what services are really needed in the community are the key, because you don't want to throw money away. When we communicated with the and began to convert, the city was excited about it, and the people of the town, because they really see the need for a hospital. And I think that it's the core need of any community besides education, and that you can offer. And you can't grow a community without one, a good school system or good hospital. So adding the different services like that, we also were under evaluation of 8 others to include. We actually have done all but signed the contracts for a nuclear medicine program, which is very profitable, above 5 patients, diabetes relief program, oncology. We're looking at these things to stabilize and actually maybe wipe away a little bit of the misnomer that the REH payment, although it's stabilized Clinton Regional, that to me is not the end game. I mean, this provides operating opportunities to think about things that you could add to your current organization to increase services. Anytime, like Kevin's doing, you add a resource to that community, it elevates the level, not just to service, but it keeps care close to home. And that's something that probably eats away at me at 3 a.m. is how can you keep patients near Woodward, near Kevin, near Clinton, near me? Because other than that, they've got to drive 40 minutes to an hour, hour and a half to seek care. So those are just some of the things. The community is grateful to be open. I think it's now having to switch the transition to what can be added to add value to keep patients close to home.
Absolutely. Thank you both. I mean, and these are two organizations that have done a lot of work. I mean, we've worked with them and we provided some documents to assist them with service line analysis and out migration reports. But these two leaders have done a lot to evaluate their communities and add services. And I can promise you, if we had these two on in another 6 months, the laundry list of additional services that they will have added will have grown. And thank you, Lynn, for bringing that up. Every single rural emergency hospital, that $3.6 million is that initial stabilization to try to get you into the black to pay those fixed costs. But in order to grow and be healthy and really meet the community needs, you have to evaluate and determine what else can you do. And these two are tremendous examples of that. Kevin, anything else that you would share with these folks? We've got some hospitals on, we've got some great state offices of rural health, some hospital associations, a lot of other interested parties. How else would you say this transition to an REH has helped you and helped your community?
Well, like Lynn said, definitely keeping the families at home and stuff, because we have an aging population. So, 50 miles to travel is too much as far as that goes. Being able to have health care where you don't have to drive 40 minutes to have that to get it for an emergency, to know that's a really big thing. One of the things I think that everyone needs to know from my perspective, what you guys provide to us that was really beneficial after the fact is, you guys went back and you looked at our charge master, made sure that, and did an audit to make sure we're capturing all that. You guys also helped us with strategic planning. You also gave us the opportunity to look at grants and stuff, so we can look to see where there's more funding as far as that goes. You also did a lot of education and compliance. We're a small hospital and all of our people have been trained on the job. So you guys gave us the technical assistance that we needed to do that. And we're going to see if it all works out, because you guys are also going to provide us with a mock survey coming up. So, there's lots of things that you guys have done that's really helped us as far as that goes. We're going to continue to evaluate all service lines. As far as that goes, we're trying to get a coalition in the county to talk about what are the healthcare needs, and then based upon that, try to partner either with them or the schools or whatever we need to do to move forward. So we have a lot of we want to do a lot more for the community now that we were stabilized and stuff. That's the big thing for us. We were not stabilized prior to that. The only criticism, or only thing, not a criticism, but only thing I think that we were not prepared for was we were critical access, and going to PPS, we were not ready for the bundling of the reimbursement. That was, we wish we'd have done more education on that. It didn't affect us negatively, but it sure was a lot of a learning curve for us. So
Absolutely. And that was probably your biggest surprise or unknown when you went in. Were there other surprises or things that were a challenge during the conversion process for you?
That was the only one from the financial side. The only other challenge was really just educating the public that we were not closed. And that was, and right now, the public understands that. We have probably the best trained nurses in the area. Every one of our nurses have got credentials from pediatrics to, ACLS to CALS training. They've got all those special certifications for emergency room. So I would put our nurses up against anybody's nurses in the emergency room in a rural area. We've really focused a lot on making sure that our nurses feel very comfortable and we can take care of everything. So I think that's a big plus.
Thank you very much, Kevin. Lynn, maybe you can share, what were some of the unknowns or surprises that popped up during this conversion process for you?
Well, I think probably Kevin kind of touched it for me, and that's when you convert, you've got to re-educate the population. The term rural emergency hospital, it kicks up the thought of, oh, you're a glorified quick care. And the truth is, we're not at all a glorified quick care. We just don't average 1.7 to 2.3 bodies in beds and lose 100,000 a month anymore. What we do is everything we used to do, and we're going to be doing more because we can afford to do that. So I think the more education you can do about what is an REH, what are the capabilities of an REH, how is this going to allow us to minister at a higher and greater level to the communities around us? And I have to bounce back just a minute about what Kevin said. The post-conversion, I know this is a question perhaps coming up, but let me just jump there with Kevin. The post-conversion, is probably more impressive from the RHRC TAC team and support than even the pre-conversion. The pre-conversion is great. Your analysis, should you or shouldn't you do that, which they did for us. And I recommend anyone on this call to please take advantage of that pre-conversion analysis. Should we or should we not? Doesn't mean you shouldn't if it came back, maybe not, but it gives you financial data and service data that tells you these are the uniquenesses that I get to work with now. So in doing that, but I think the communication to the community is key, and we did that through everybody but the Girl Scouts, the Lions Club, the Rotary Club, the Club, the golf clubs. We sponsored a golfing event, which is a big deal in most small towns. The golf course is where everybody goes, right? And also we unified our message. I can't speak to this enough, and I'm sure Kevin is nodding, but the issue with leadership in small communities, everybody on your payroll has to be educated about it. My staff had to know before we did anything. So when they went out to the communities, because they are the communities, then they've got to know, what are we doing? Because they're going to be asked by their folks at church, at the grocery store, at ball games, and just in the community, what's going on out there? What's going on out there? And so you need to make sure, in my opinion, to communicate with your staff, because when I came into the REH conversion, my payroll was running about 187,000 every 2 weeks, and at conversion it was 127. So you've got to have a positive message about, well, what's going on with that? Well, thank God I had probably 2/3 PRN, but when you do that, everybody's got to be marching forward to a better future. So communication to the staff is number one. Communication to the communities, wherever those communities gather, however they get their messaging, Facebook or the paper, radio stations, or just go in the communities. I think that's really a big key, Ken, and not only pre but post. That way you keep everybody in the loop, and they can be rejoice with you in the direction you go.
Thank you very much. I appreciate that. Taking a cough drop, so maybe I don't cough during the next answer. But the REH program has its pluses and minuses. Kevin, if you could wave that magic wand and change some of the statute or the requirements of the REH program, what would you like to see changed and things like that?
For us, I would like to see us get back the 340B program, because we did participate in that prior to the conversion, and that would be very beneficial. I mean, that would be a huge benefit for us. I mean, I think that of all things, that'd be the most critical thing. The other thing that we've found out that's in our state is that the Office of Rural Health can't help us as much as they used to, because an REH is not considered a designation with their stuff. They'll help us what they can, but most of the federal monies are only for rural critical access hospitals or rural hospitals, but we don't qualify for most of that grant funding. So that's the only other thing I'd like to see change somehow going forward. So
absolutely. I know we have a lot of state Office of Rural Health on, and I want to tell you that the partners that we've seen in these states continue to be absolutely critical to the success of these hospitals. And so what we've seen is the state Office of Rural Health can still involve the REHs in the education and the training, but unfortunately, some of the flex grants and SHIP grants and other things like that are not eligible. So I think that's what, Kevin, you were really getting.
That's right. Yeah, as I say, the Office of Rural Health does help us a lot, but there is certain things they cannot help us because that's just the way they're funded. So
down the road, maybe we can help get some of those changes made. But our partners here, we still need you. These hospitals still absolutely need you. So involve them, invite them to participate in the webinars, all of those things. But if it's specifically tied to dollars, obviously your flex program is going to be specified that you can only spend those monies for critical access. But I think almost all of the states that we've seen are able to at least continuing to invite and enable them to participate where it doesn't add any additional cost to the organization. So that's just Ken's
Yeah. And I agree with you there. I mean, I think our Office of Rural Health is good, but I just meant if I could just change the language to where they would consider an REH and some certain things the same as a critical access hospital, I guess is what I'm saying. So
Kevin still wants the flex and ship spending grant. So
that's right.
and absolutely he should. Lynn, what about you? With your magic wand and your innovation?
Well, I think, swing beds would be a good thing. 340Bs would be a good thing. With the cost of medication just unreasonable for any institution, that's obviously a key. Um, I have a tendency to pick up the ball and run whatever lane's open. We still work on grants every day. I spent the last 3 or 4 months trying to determine where the 223 million are going to go, because I don't think Kevin's going to get any. I don't think I'm going to get any in Clinton. And that's one of the reasons I went to San Antonio for the AHA Rural Health Leadership Conference. And of course, got to see my friends from REH down there in their booth. And I met with several people, and it doesn't seem there's holes in that in regards to we needed to apply for very specific use of funds. And we found that it was not in as much alignment as I would have hoped to be. So instead of crawling up in a ball in a corner and crying about it, we just get back on the horse and figure out what we can do to increase that. And so I think swing bed and 340B, I think that leasing your space to a 340B or other, the problem is in the state of Oklahoma, I think yesterday I read that 44 hospitals are in jeopardy to close in the next 24 to 36 months, and 22 nursing homes. The nursing homes are struggling for the same reasons why we are in hospitals, rural hospitals, is the volume is dropping off. But yet you see volumes in Woodward up by Kevin with 1,000 or two people. It's not newborns. It's not, you don't go to churches there and everybody's 20 to 30 years old. Everybody's there because that's their social group. So you've got to really be careful with what's going on there. So I think those two particular services may help with the downfall of nursing homes in rural communities.
Thank you very much, Lynn. I mean, those are the same things that these two have said that we're hearing from all of the 46 REH hospitals. They'd love to see swing beds. They'd love to see 340B. They'd love to see participation in some of the grants that were there. I mean, it's still a question on these transformation funds. There's some good things in Oklahoma that will probably, on some of these micro grants, be able to help you in some of their other goals. But each state obviously has their own plans and will have different levels of help for REH hospitals in states, depending upon what those priorities are. So, and of course, we work and try to help our hospitals that have converted. So that may be a great transition. Kevin, you've talked a little bit about this, about how the REH TAC has helped you organizations and some of the things that have helped on the post-conversion support. Maybe you could go in and talk about how we're helping you improve the operations and kind of keep those processes growing and going.
Sure. So whenever I look at projects and stuff, I reach out to the RTAC team to see if there's any, if you guys have any education or if anybody else has done that. So you guys are always good about responding either with a contact person for me to get with, or actually, give me some, at least a direction to go. Like I said, the compliance thing that you did for the education piece for us, that was huge. I mean, it took us, I think it was like almost 6 months, but man, did it really bring the education level up for my managers and stuff that they didn't have prior to that. So I think that's a big deal as far as that. So when we get ready to move forward, the monthly meetings that you guys perform for us to participate in, I think that's great too. I think the benchmarking of our financial indicators are a big deal. As far as that, we do participate in that as well. So I think there's a lot of things that you guys do that's very beneficial after that you make the conversion to make sure that that everything's looking right and we can compare to other like facilities. Because I mean, I can't compare myself to another critical access hospital because we're not the same anymore. It's just there's just differences now. So it's good to have the other facilities like us together as a group. So
Thank you very much. Lynn, your perspective.
Well, I've thought back through this and contemplated on even this morning. I think one of the things that the REH TAC team helped with on a consistent basis was really transparent assistance um, before, during, and after. The amount of help, I don't know that you can define it in a paragraph. There are probably 24 different departments or segments that, as Kevin said, when you have a need, you'll have an answer within 24 hours, at least to someone you could go to and check it out. But Ken and Kayla, who is another one of our regional representatives, they engage. Um, I know most of you, even in state organizations, it's hard to find an organization in healthcare that'll engage with you. And this is critical with the help in an REH conversion. And they do that. They engage before, during, and after. Um, Participation, if anyone has an opportunity to participate, probably in the reverse site visit, it's a 2 days or so worth of valuable information, changes that are upcoming, just a great resource, the roundtables. That's where you kind of understand that you're not the only person struggling across the country. You have 769 hospitals, Becker said, are due to close, and half of those are or more are rural. I think 67% are rural. Just support, and Kevin mentioned too, the analysis that REH offers, these are free. These are with the relationship, and so I would encourage you to engage and to have them define, is this a good move or not? But then it's a shift in your thinking, because now you're almost a retail facility. I'm using these terms because I relate to them. Maybe you won't, but what can I do now? What can I do now to stand up these services, to strengthen the revenue streams outside of the REH facility payment?
Thank you very much, Lynn. Kevin, looking back, what would have you done differently during the process? I mean, obviously we've touched on understanding the new billing processes, but what else would have you done differently?
well, we also talked about the reimbursement. We definitely do that. I would like to try to have educated the public a little bit differently than what we did. I know we did the town hall meetings and stuff, but we probably should have been even more out front about what was happening. I know we did it in a kind of a short timeline, but I think the more education and stuff that's out there for the public to hear about what this really means for you and where it's going to be is really important. Of course, we were one of the first ones to convert, so we had no one to compare to, and so nobody understood what it was. But to me, it's just getting out in front and making sure that everybody's educated, staff, the public, and of course your board members as well. So
Thank you very much, Kevin. Lynn, putting you on the spot, same question. What
You
would have
know
you
me.
done differently?
You know me, Ken. I'm never on the spot. I have to echo what Kevin said. Even though we felt like we did a good job communicating with the public, you learn very quickly that the perception of what you did in converting to REH didn't land as far as your preemptive communication, and I think probably allocate more resources, do a better job of communicating with the services that are going to continue to render. I'm a big guy on transparency. Sometimes I don't want to be, because it hurts, because you get egg in your face. But the truth of the matter is, transparency when converting to an REH really is probably some of the best decisions that anyone could do. Now, at a critical access hospital, yeah, maybe if it's ran effectively, but you've got to have the population to support that. So I think communicate with the community is probably the number one thing we could have done better, and allocate some more resources. But and also what Kevin said, I can't emphasize enough your transparency before this goes to print with your staff. I actually, because I love transparency and teaching up and training and doing going forward and leading, I involve all of my leaders in as many of the phone calls with REH that I can. In fact, my director of nurses scheduled the mock survey, and I want each one of them to get involved at every level they can and want to with REH, because really, I don't need them if I'm having to do it, and I don't have to re-explain to them. They're better at what they do than I am, so I would take advantage of that as well. But preemptively and post conversion, communicate, communicate, communicate.
Thank you very much. We appreciate all of your comments. So Kevin, I'll go back to you. Again, we have a number of hospitals on the call today. We've got a number of state office of rural health. We have hospital associations. We have a lot of rural partners and rural organizations. What advice would you give to them?
I would give, well, first I'd have you guys do an analysis first to see what that is. And then just be prepared for what changes you have to make. Because I mean, there's quite a bit of, you have to develop an action plan and stuff like that. So there's things that you have to do. I mean, that's probably it. For us, it was very successful. I just can't even reiterate how successful it was, because we were close to being almost closed, to where we have got now cash in the banks and stuff like that, and all that stuff. So, but it's just just need to educate yourself, I guess is what I should say, and get with you guys that know what you're doing as far as educating them to help make an informed decision. So.
Thank you very much, Kevin. Lynn.
Well, I think I'm going to go up the ladder a little higher than Kevin. I agree with everything he's saying, but since we have state organizations and things, I've worked with Keith Reed at the Oklahoma State Department of Health and several others, and I assure that my communication with them of my process for educating our team and myself about the REH as well as conversion, I probably sent several emails a day. And when you are able to do that, you recognize we're all working at this together. This is new to everyone. And when we're able to get to that level with the Keith Reed and his departments and different folks there, they were very responsive, I would say. And I would say to state organizations and rural health, REH is not a threat. It's not. In fact, it's a blessing from. I'm going to say this, and I know that it's a weird thing to say, but it's a blessing from our government and the team that is put together that got the rights to distribute this. They are the Rural Health Redesign Center and the TAC team with Ken and his the rest of the entire group all the way back up Northeast. They are exceptional in what they do. I would use every resource you can. Ken knows, I'm sure Kevin too. I'd be happy to share off screen and offline what I've experienced, what I know, and how did that play into 42 years of healthcare. I'm excited about it. I think that the outcomes on rural healthcare, we can't handle it ourselves. We can't solve the problems. And unfortunately, legislature's got so many other things to do. So quite frankly, my opinion is after Ken, 2 years of being part of at least an ancillary part, now a real part of REH, this is probably the closest thing to rural health solution that I can find, and I look every day. So I would recommend, and as Kevin said, engaging, be a part of the education of your state level, meet, talk, read, and together we're all stronger when we work together.
Well, again, thank you both very much. I mean, there's been a lot of questions, and I just want to thank these two. I mean, one for their time, but more importantly for the efforts that they put in to affect change in their communities. For Lynn's case, there was not a hospital there, and had he not gone there, there would not have been. For Kevin's efforts, had he not made change, it's very likely that his hospital would have probably had to close, or at least dramatically change the services. So REH is not the perfect solution for all hospitals. In fact, when we do these financial models and do this analysis for hospitals, probably half the hospitals that we do the models for shows them that maybe staying as a critical access hospital or maybe staying as a PPS hospital because of the volumes they have or things may be a better model. But for about half the hospitals that we do the surveys for and we do these models for, it demonstrates a path forward, a path towards financial stability, a path forward to making a difference with the health of these patients. Both of these organizations, because they're now stable, are doing some pretty exciting things. They're making changes through interaction with patients that are helping to improve their health, not just treat the health. And that's why all of us went into healthcare in the difference. I mean, together between the three of us here, we probably got well over 100 years of service, and we're excited. All three of us are excited because these communities deserve and need healthcare. A good friend of mine in Colorado years ago said, "Where you live shouldn't determine if you live." And for us to be able to have the opportunity to interact with wonderful hospital leaders and wonderful hospitals all around the country, and to help keep these communities having care and having access to this great service is a blessing. And so I know our time is well spent. We only have a couple minutes left. So I will be quiet, which Lynn and Kevin know is hard for me to do, but I'll be quiet and see, are there any other questions from anyone on the call? If so, please put them into the Q&A and our team can try to address them. We just want to make sure your specific questions are answered.
Hey, Ken, I have a comment, if I might.
Please.
I would challenge and encourage anyone on the call, if you make a decision to engage in REH, do not be complacent. I think that this is something that is a new business model for you or for hospitals in your jurisdiction in the state. So I would encourage you to be proactive and aggressive and take advantage of everything it has to offer, and recognize this is a new face on expanding services in the communities that you are over, and if you're a CEO or administrator of a hospital, take it like it's a new business model and run as fast and as hard with the resources that you're provided.
Thank you all. I'm going to share my screen back again, or try to. And there we go. And we wanted just to kind of show you some of the next steps. When you have the opportunity to look at this PowerPoint, if you obviously, as Rachel said, it will be on our website in about a week. If any of you particularly need or would like copies of it, let us know and we can send this. We've got hyperlinked here just a lot of information about the REH program. We have fact sheets from CMS. We have frequently asked questions, which we've compiled from answers from CMS. We have just lots and lots of information available to make sure that as you evaluate and look at the program, you've got all of the information there. And again, lastly, our contact information. Any questions that you have at any time, reach out to us. REH support at rhrco.org is the email. You can send us questions. We're thrilled to get them. And if we don't have answers, we go to CMS and we'll get you the answers. But we're just pleased and excited to be able to be partners in this journey. Again, I think our time is well spent. So thank you all for joining us today, and we certainly hope to be able to help you help your hospitals in the future. Thank you again.
Thank you, Ken.